Feeling a bit buried under your Crohn's disease revision notes, especially maybe with the MSRA coming up?
It happens.
Yeah, well, you're definitely not alone. Think of this deep dive as your fast track. We've waded through the key stuff to give you the core need-to-knows on Crohn's, what it is, the why, and crucially, what you need to remember.
Exactly. We're aiming to break Crohn's down so it actually makes sense for revision. We'll cover the definition, the causes, risk factors, what's happening physiologically, what else it might be mistaken for,
Right.
how common it is, especially here in the UK, how patients present, the investigations, management, prognosis, and those potential complications. Basically, making it stick.
Okay, let's get into it then. What exactly is Crohn's disease?
So, at its core, Crohn's disease is a chronic inflammatory bowel disease. Chronic meaning long-term, obviously.
Right, long-term inflammation.
Yeah, affecting the digestive tract. And it's quite widespread. It can pop up anywhere from the mouth right down to the anus.
So not just one specific spot.
Not at all. Yeah. And fundamentally, it's an autoimmune thing. The body's immune system gets confused and attacks healthy gut tissues. That's what drives the inflammation.
Autoimmune can be anywhere. Are there, like, key features that really show Crohn's?
Absolutely. Okay, so it's a type of IBD. Often hits the terminal ileum end of the small intestine and the colon. But crucially, it can show up anywhere.
Okay.
The really unique feature, though, skip lesions.
Skip lesions.
Yeah, you get a patch of inflammation, then normal bowel, then more inflammation. It jumps, it skips. It's not continuous.
Ah, okay. Makes sense.
And the inflammation itself is transmural.
Meaning?
It goes deep,
Mm-hmm.
right through all the layers of the bowel wall. Think like a deep burn, not just surface stuff. This deep inflammation is why you sometimes see things like fistulas forming.
Gotcha. Deep and patchy.
Exactly. Plus, you see this pattern of chronic relapses flares, followed by remission. And it can lead to serious complications, like bowel obstructions or even perforations. Oh, and don't forget extraintestinal manifestations.
Right, the problem's outside the gut.
Yeah, things like uveitis in the eyes, arthritis, skin issues like erythema nodosum.
Okay, so skip lesions, transmural inflammation, those are the big ones. We had a memory tip. A Crohn always skips town, skip lesions, and can affect you from your crown to your gown, anywhere in the GI tract, plus extra-intestinal.
That works, captures the key ideas.
Let's try a quick question then. A 25-year-old presents with on-off tummy pain and diarrhea. Colonoscopy shows inflammation in the terminal ileum and ascending colon, but with patches of normal bowel in between. This pattern points most strongly to options: Crohn's, UC, IBS, infectious colitis.
Well, with those areas of normal bowel in between the inflammation, that's got to be Crohn's disease. Those are the skip lesions we were just talking about.
Perfect. Okay, so what actually kicks this whole thing off? The etiology. This is where it gets really interesting, right? The root causes.
It really is fascinating and pretty complex. Crohn's isn't down to just one thing. It's multifactorial. Think of it as like a mix of ingredients that have to come together in the wrong way.
That combination deal.
Exactly. We're looking at genetics, environmental factors, and the immune system all interacting.
Genetics, okay, so it runs in families sometimes.
Definitely. There's a clear genetic predisposition. We've even identified specific gene variations, like NOD2 card 15, that increase susceptibility. These genes are involved in how the gut immune system recognizes bacteria.
So faulty wiring in the immune response genes?
Sort of, yeah. But it's not just genes. Environmental factors are huge, too.
Like what?
Things like diet, definitely smoking, maybe even past infections. These can act as triggers in someone who's already genetically susceptible. They might kickstart that faulty immune response.
And that leads to the immune system going haywire.
Pretty much. That's the immune dysfunction part. The gut's immune system doesn't regulate itself properly, leading to that chronic ongoing inflammation.
So it's like a perfect storm, the genetic tendency, environmental trigger, and then the immune system overreacts and just keeps going.
That's a really good way of putting it. The exact trigger, the precise sequence. We're still figuring that out. But we know these elements, genetics, environment, immunity, they all intertwine.
Right, a complex web. Okay, so who's more likely to get Crohn's? What are the key risk factors we need to flag for revision?
Well, that genetic link is a big one. About 15–20% of people with Crohn's have a family member with IBD. And get this, the concordance rate in identical twins is around 70%.
Wow, 70%. That really hammers home the genetic part.
It does. Then there's smoking. Major risk factor. Increases the risk maybe 3 or 4 times, and it tends to make the disease more severe.
Right, smoking is a big no-no.
Huge. Diet might play a part too. Some links suggested with high-fat processed foods, though the evidence is still debated. Ethnicity is another factor. People of Ashkenazi Jewish descent have a notably higher risk.
Interesting. Any others?
Maybe previous gut infections could be a trigger, and things like chest infections or taking NSAIDs can definitely exacerbate things once you have Crohn's.
Okay, so our memory aid. A smoker, smoking, from an IBD family, genetics, eating processed food, diet, with a Jewish heritage, ethnicity, and recent GI upset infection, might be at higher risk. Helps pull it together.
Good summary. So now let's get down to the nitty-gritty what's actually happening inside the bowel wall, the pathophysiology.
Okay, we know the immune system's misbehaving. How does that translate into the damage?
So the core issue is that immune dysregulation in the gut. This drives the chronic inflammation. And as we said, what's really characteristic of Crohn's is that the inflammation is transmural.
Going through all the layers.
Exactly,
Huh.
piercing right through. And this deep inflammation can cause a whole cascade of problems, ulcers, strictures,
Ortho narrowings, right?
yes, narrowings of the bowel, and fistulas, those abnormal tunnels connecting bits of bowel or other organs.
And all that damage is what causes the symptoms, the pain, the diarrhea.
Precisely. It messes up the normal working of the intestine, leading to pain, diarrhea, problems absorbing nutrients, malabsorption. And again, it's that combination, genes, environment, faulty immunity driving it all, even if we don't know the exact first domino to fall.
Right. Immune system attacks deeply disrupting function. Okay, so when someone comes in with these chronic gut symptoms, what else could it be? What are the key differentials for exams? What does this all mean?
Critical question. Top of the list is usually ulcerative colitis, the other main type of IBD. But remember the key difference. UC inflammation is continuous. Crohn's has those skip lesions. Different pattern, different immune cells involved.
UC versus Crohn's, the classic differential. What else?
We need to think about infectious colitis, IBS, irritable bowel syndrome, which is common but not inflammatory in the same way, and celiac disease, the reaction to gluten. Sometimes it's hard to tell initially, and it might be labeled indeterminate colitis.
Okay, so other chronic gut inflammation causes. Any non-inflammatory mimics?
Oh yeah, quite a few. Simple infectious gastroenteritis needs ruling out, obviously. Less common infections like TB or actinomycosis. Then there are things like certain tumors, carcinoid, lymphoma, systemic conditions like Behçet's disease.
Right.
And you've got to consider bowel cancer itself, ischemic colitis, lack of blood flow radiation, or drug-induced colitis,
Yeah.
especially from NSAIDs. Diverticulitis, even acute ileitis can look a bit like appendicitis sometimes.
Wow, okay, so thinking broadly inflammatory, infectious, even neoplastic causes is key for the differential.
Exactly. Now let's shift to who gets Crohn's, particularly in the UK. The epidemiology helps put it in context.
Okay, prevalence, affected groups. What's the picture for Crohn's in the UK?
Well, the bad news is it's increasing worldwide, including here. In the UK, the prevalence is roughly 1 in every 650 people.
1 in 600, so not exactly rare.
No. Interestingly, the highest rates are actually in places like Australia, Canada, and Northern Europe. Maybe environmental factors playing a role there.
And within the UK, any specific groups?
Well, family history is a big risk factor, as we said. It hits men and women pretty much equally. And there are these 2 age peaks for diagnosis, typically 15 to 30 years old, and then another peak later, around 50 to 70.
2 peaks. Interesting.
Yeah. And sadly, we are seeing more diagnoses in children, and a fair chunk of them, maybe 20%, need powerful drugs like biologics, suggesting it could be pretty severe early on. It's also associated with slightly higher mortality, a standardized mortality ratio of about 1.38.
So it has real long-term implications. Okay, on to the clinical picture. How does Crohn's actually show up? Signs and symptoms?
It can be really varied, but common things include abdominal pain, diarrhea, sometimes with blood weight loss without trying, feeling really tired, loss of appetite, maybe a fever, anemia.
And perianal problems too?
Yes, definitely. Things like abscesses near the anus, fistulas, fissures, those are quite common in Crohn's.
What might we see on examination? Any clues?
You might spot perianal skin tags or ulcers. And then there are those extraintestinal signs, skin, joints, eyes, liver issues. It often presents in late teens or early adulthood, but sometimes the first signs are vague, just weight loss and feeling drained.
And you said pain is maybe more common in kids, diarrhea in adults?
Generally, yeah. Pain seems more prominent in pediatric Crohn's, diarrhea maybe more so later on. And those extraintestinal features are more likely if there's colitis or perianal disease.
So the history and exam points you in the right direction.
Absolutely. Diagnosis hinges on that suggestive story, exam findings, and then confirmation with tests like colonoscopy and biopsy, and ruling everything else out, of course. Remembering those risk factors helps too. Family history, age peaks 1540 or 6080, white ethnicity, Ashkenazi Jewish background.
And on exam specifically.
You might feel tenderness in the right lower abdomen, maybe even a mass. Look for mouth ulcers, those perianal lesions tags, fistulas, abscesses, maybe cult blood on a rectal exam. And keep an eye out for skin signs like erythema nodosum or pyoderma gangrenosum.
Okay, let's quickly recap some of those extraintestinal signs again.
Sure. Skin, clubbing, erythema nodosum, pyoderma gangrenosum. Eyes, conjunctivitis, episcleritis, urinaritis. Joints, large joint arthritis, sacroiliitis, ankylosing spondylitis. Liver, fatty liver, rarely PSC or cholangiocarcinoma, you can get granulomas elsewhere. Kidney stones, bone issues like osteomalacia, malnutrition is a big one, and very rarely amyloidosis.
Quite a list. Shows how systemic it can be. And the disease course usually involves ups and downs.
Typically, yes. Flares or acute exacerbations followed by periods of remission. And in children, watch out for poor growth and delayed puberty. That's a really important aspect.
Got it. Okay, so that covers the clinical side. Now, investigations. What tests are crucial for diagnosing and assessing Crohn's?
Right, investigations are key. We usually start with blood tests, looking for inflammation markers like CRP and ESR, checking iron levels for anemia, B12, and folate for malabsorption. A metabolic panel gives you albumin, calcium, cholesterol clues about chronic or severe disease.
And the inflammatory markers themselves tell you.
Well, raised CRP and ESR suggest inflammation. A really high CRP could mean active disease or maybe a bacterial complication on top. Tracking them helps see if treatment is working. Then, stool tests.
Right. Ruling out infection.
Exactly. Stool culture and microscopy for bugs. But the really key one here is fecal calprotectin.
Ah, calprotectin. Very useful.
Hugely. It's a protein released by neutrophils in the gut lining when there's inflammation. It's very sensitive. A normal level makes inflammatory bowel disease much less likely high negative predictive value. If it's high, it strongly points towards inflammation and means you need to investigate further, usually with...
Colonoscopy.
Usually, yes. But before that, imaging. A plain X-ray might show bowel dilation or sacroiliitis. A CT scan of the abdomen is great for seeing disease locations, skip lesions, thick walls, inflammation, abscesses, fistulas.
So CT gives a good overview.
It does. An MRI of the abdomen or pelvis can be better in some situations, especially for complex disease or perianal assessment. But the gold standard for diagnosis is usually an ileocolonoscopy, going in with a camera, ideally getting into the terminal ileum.
And biopsies.
Absolutely essential. Tissue biopsies taken during the scope are what confirm it. You look for that transmural inflammation, maybe those non-case-eating granulomas under the microscope.
So colonoscopy with biopsy seals the deal. And fecal calprotectin is that helpful, non-invasive first step.
Exactly. It really helps triage patients. Other tests, maybe pelvic MRI specifically for perianal disease. If someone has upper gut symptoms, maybe an upper endoscopy, gastroduodenoscopy with biopsies. Laparoscopy is rare now for diagnosis, maybe in tricky cases or kids.
Okay, brilliant. Let's say we've got the diagnosis confirmed. How do we manage Crohn's? What's the treatment plan?
Right, management is long-term. Two main aims. Induce remission, get the inflammation under control when it flares, and then maintain that remission, keep things quiet.
First things first, lifestyle.
Absolutely. Strongly advise smoking cessation. Can't stress that enough. It genuinely makes the disease worse. Maybe caution with NSAIDs too, some link to relapse risk, though evidence isn't totally clear-cut. Same for the combined pill, potentially.
Okay, quit smoking, top priority. What about meds for inducing remission? Getting a flare under control.
Often first line is glucocorticoids. Prednisolone usually, oral or IV if severe. Sometimes topical steroids like budesonide for ileal or right-sided colonic disease. They work fast to dampen inflammation.
Steroids first. Any alternatives?
In kids, sometimes enteral feeding a special liquid diet can induce remission instead of steroids. Less common in adults. 5-ASA drugs like mesalazine are generally less effective than steroids for inducing remission in Crohn's, but might have a role in milder colonic disease.
What about stronger drugs?
Immunomodulators like azathioprine or mercaptopurine, AZA6MP, come in, but more for maintenance. They take time to work, so not usually used alone for induction. Methotrexate is another option, sometimes used instead of AZA6MP.
And if those don't work, or for severe cases?
Then we move to biologics, like infliximab. It's especially good for refractory disease stuff that hasn't responded, and for fistulizing Crohn's. often combined with azathioprine or methotrexate for better results and less antibody formation. For isolated perianal disease with infection, sometimes antibiotics like metronidazole help initially.
Okay, that's for getting things under control. What about keeping it that way, maintaining remission?
Again, number one, stop smoking, then drugs. First-line maintenance is usually azathioprine or mercaptopurine, crucial to check TPMT enzyme activity before starting these because some people metabolize them poorly and are at high risk of side effects.
TPMT testing first.
Yeah.
Got it. Second line for maintenance.
Methotrexate is the main alternative if AZA6MP aren't suitable or don't work.
And surgery, does that come into play?
Unfortunately, yes, for many people. Maybe up to 80% will need surgery at some point. Things like resecting a diseased bit of bowel, widening strictures, that's scripturalplasty, or dealing with perianal abscesses and fistulas.
80%. So even with good medical treatment, surgery is common.
It is. Maybe half might still need surgery despite meds. It really highlights why things like smoking cessation are so important. Treatment has to be tailored by specialists. Disease activity, location, response, patient factors all play a role. The aim is always remission and quality of life. We use scoring systems like CDAI or PCDAI in kids to track activity and response. And regular monitoring for complications like cancer screening if the colon's involved is vital.
How about managing those extra intestinal problems?
Depends entirely on the problem. Arthritis might need specific drugs. Skin stuff like erythema nodosum often gets better as the gut inflammation improves, but pyoderma might need targeted treatment. Eye issues often need steroid drops. Liver disease is complex, rare cases might need a transplant. We also need to watch bone health, especially with steroid use, maybe bone density scans.
Yeah.
And managing fistulas.
Right, fistulas, how are they treated?
Simple ones without symptoms might just be watched. If they cause symptoms, often antibiotics, first metronidazole or ciprofloxacin, then medical therapy like azathioprine, mercaptopurine, or infliximab is key to try and heal them. Surgery is often needed, too, for exploring, draining abscesses, or complex repairs.
Okay, a really comprehensive management plan. What's the long-term outlook, the prognosis?
It's really variable. Depends on disease extent, severity, treatment response, individual factors. It is a chronic condition with those flares and remissions. But, and this is important, many people can achieve long-term remission and live pretty normal lives with good management.
But it can be unpredictable.
It definitely can be. Some people have a tougher course, need multiple surgeries, develop complications. About half might need surgery within 10 years of diagnosis. So sticking to treatment, regular follow-up, managing risks, it's all crucial. Certain things might suggest a poorer prognosis early on, having perianal or stricturing disease, losing a lot of weight initially, needing steroids long-term.
Okay, so variable but manageable for many with the right approach. Finally, what are the potential complications we need to be aware of?
Okay, complications. Broadly, bowel ones and non-bowel ones. In the bowel, strictures causing obstruction, fistulas connecting things that shouldn't be connected, perforation, a hole in the bowel, which is an emergency. Acute dilation or massive bleeding can happen too. And importantly, an increased risk of colorectal cancer, especially if the colon is extensively involved. Crohn's colitis.
That cancer risk is a key long-term concern. What about complications outside the gut?
We mentioned osteoporosis often linked to steroids and inflammation. Renal disease, sometimes ureters get obstructed. Nutrient deficiencies are common: iron, B12, folate. Gallstones and kidney stones can happen, especially after certain surgeries like right hemicolectomy, due to changes in bile acid and oxalate absorption. In kids, growth delay and delayed puberty. And pregnancy needs careful management. Active disease increases risks, though infliximab seems safe to continue.
That's quite a list. Really underscores why good control is so important.
Absolutely. Minimizing those risks is a huge part of long-term care.
Okay, let's wrap up this deep dive on Crohn's. For anyone revising for the MSRA or just wanting the high yield points, remember the skip lesions and transmural inflammation. Those are the pathological hallmarks.
Right.
Remember, it stems from that mix of genetics, environment, and immune dysregulation. Key symptoms: abdominal pain, diarrhea, key investigations, fecal calprotectin for inflammation, ileocolonoscopy with biopsy for diagnosis, and management is stepwise: induce remission, often steroids, maintain remission, immunomodulators like AZA6MP, and remember, surgery often plays a role. Smoking cessation is critical.
And the bottom line is, yes, it's chronic, but but with good proactive management, people can achieve long periods of remission and have a good quality of life.
Definitely. And if you want to cement this knowledge and find more great MSRA revision resources, do check out pastthemsra.com and freemsra.com.
Lots of useful stuff there.
Absolutely. Thanks so much for joining us for this deep dive into Crohn's disease.